Welcome to the Deep Dive. We take your sources, cut through all the noise, and really try to pull out the most important nuggets of knowledge for you. Today, we're embarking on a really crucial journey into two pillars of your health: managing hypertension or high blood pressure, and understanding your lipid profile, your cholesterol and triglycerides. You've armed us with a pretty comprehensive stack of material here. We've got everything from the latest guidelines by the ATAC, the European Society of Cardiology, KDI-GO, plus those landmark studies that have genuinely reshaped how we think about this stuff. So our mission right now is to give you a clear shortcut to being well-informed about these often silent threats to your cardiovascular health. We'll try to uncover some surprising facts, maybe challenge some conventional wisdom, and definitely equip you with actionable insights that can really profoundly impact your long-term well-being.
It is quite striking, isn't it, how much our understanding has transformed? I mean, consider this. As recently as 1945, there just wasn't any medical consensus to treat even dangerously high blood pressure. And that lack of intervention, it led to tragic situations, like President Franklin Delano Roosevelt's death from a hemorrhagic stroke. Just imagine. It wasn't really until the 1950s that direct scientific evidence came out, unequivocally linking elevated blood pressure to adverse outcomes. That finally paved the way for the guidelines we rely on today.
Yeah, that historical context, it really sets the stage. It highlights just how far we've actually come. So, okay, let's start by grounding ourselves. What does high blood pressure actually mean according to these latest guidelines? So, normal blood pressure, less than 120 over 80 millimeters. Then we have elevated blood pressure. That's where your systolic, the top number, is between 120 and 129.
Yeah.
But your diastolic, the bottom number, is still less than 80. Stage 1 hypertension, now that kicks in when your systolic hits 130 to 139, or your diastolic is 80 to 89. And finally, stage 2 hypertension, defined as a systolic of 140 or higher, or a diastolic of 90 or higher. This categorization, it isn't just academic, right? It really shifts how we approach your risk.
Exactly. And what's particularly significant here is that escalating risk, even at those lower sort of elevated levels, our sources point out that for every 5 millimeter Hg increase in diastolic pressure and every 10 millimeter Hg increase in systolic, well, there's a staggering 28% increased risk of death from coronary heart disease.
Wow, 28%?
Yeah, and this holds true even for blood pressures below that 440/90 mark.
So even mildly high matters.
It means that what might seem like only slightly elevated blood pressure, it's already a substantial signal, something that warrants attention.
Okay, so how does this translate to, your personal health journey? Even if you have been diagnosed with hypertension yet, certain factors can strongly predict your likelihood of developing it down the road. The landmark Framingham study that really laid out these key predictors, things like your systolic and diastolic readings, BMI, body mass index, your age, gender, smoking history, and whether your parents had hypertension. And what's powerful about this list is these are all easily identifiable pieces of information, stuff that's often gathered during just a routine physical exam.
That brings up such a critical point, though. How accurate are the blood pressure readings we're relying on? Many office measurements can actually be flawed just because they're not taken under the ideal conditions.
Okay, so this next insight is, I think, really powerful because getting an accurate reading is just foundational to everything else we're going to talk about. So to measure blood pressure correctly, you should be seated calmly in a chair for at least 5 minutes beforehand. Your arms should be resting comfortably on an armrest or a desk, on a bare arm, no clothing underneath, and the cuff has to be the right size for your arm. Crucial. And critically, neither you nor the person taking the measurement should talk during the process. And on an initial visit, it's recommended to check it in both arms. Then you focus on the arm with the higher reading for all the next measurements.
Makes sense.
Oh, and you should also avoid exercise, smoking, or caffeine for about 30 minutes beforehand.
Beyond just the technique, we also have to account for psychological factors. Many of you might have heard of the white coat effect, where your office readings are higher than your readings at home. But there's also the opposite, masked hypertension. That's where your office readings are deceptively lower than what your blood pressure actually is throughout the day.
Interesting.
Yeah, and that's exactly why the U.S. Preventive Services Task Force now recommends confirming a diagnosis of hypertension with out-of-office readings. So moving beyond just a single clinic visit, using methods like 24-hour ambulatory blood pressure monitoring or ABP.
The monitor you wear.
Exactly. You wear a small, portable device. It takes your blood pressure automatically throughout a typical day and night. It gives us a far more accurate, sort of real-world picture than just one snapshot reading in the doctor's office. And for ABPM, an average blood pressure over 125/75 is generally considered hypertensive.
Okay. And it's also important to remember that not every single elevated reading automatically means you have hypertension. There are several common factors that can temporarily spike your readings. Things like the simple stress of seeing a new physician, or maybe being in pain, or consuming caffeine or alcohol, using over-the-counter decongestants or aids like ibuprofen,
Yeah, those can do it.
even certain prescription medications like oral contraceptives or some antidepressants. Context is definitely key.
Okay, so if these temporary factors aren't the issue and we've confirmed consistently elevated readings, what's often the most powerful initial step you can take? Our sources are crystal clear on this. It often begins not with a pill, but with the profound power of lifestyle changes.
Absolutely. The data really shows that diet and exercise can be just as effective as pharmacotherapy, as medication in lowering blood pressure. And you don't even need massive changes sometimes to see results. Even a modest weight loss can make a significant difference. For every kilogram of weight lost, if you're overweight or obese, you can expect about a 1 millimeter Hg reduction in blood pressure.
Just 1 kilo makes a difference.
It adds up. And sodium intake. While the optimal intake for most people is less than 1,500 milligrams a day, the average U.S. adult consumes something like 4,000 milligrams daily.
It's massive.
It's astonishing how much salt is just hidden in prepared foods, packaged stuff, canned foods.
Yeah, you have to read the labels. When we connect this to the bigger picture, dietary patterns like the DISH diet, that's dietary approaches to stop hypertension in the Mediterranean diet, they've shown truly significant results. The DISH diet, which is rich in fruits, vegetables, low-fat dairy, and low in saturated and total fat, it can reduce systolic blood pressure by over 11 millimeter Hg.
11 points, just from diet.
Just from the diet. And then if you add sodium restriction to the DISH diet, you can drop it another 5 to 6 millimeter Hg. And the Mediterranean diet, famously linked to lower cardiovascular outcomes in the 7 countries study, it also effectively lowers both blood pressure and cholesterol.
Okay, so diet's huge. What about beyond diet? Activity.
Foundational. Consistent physical activity is just foundational. Sustained aerobic exercise, aiming for 90 to 150 minutes weekly, can reduce systolic blood pressure by about 5 to 8 millimeter Hg. And resistance training, lifting weights or using bands, offers similar benefits.
Right. You mentioned a statistic earlier about inactivity.
Ah, yes, it's quite striking. Eliminating physical inactivity globally could increase overall life expectancy by almost 3/4 of a year.
That's incredible. It's a measurable impact on how long people live.
Yeah.
It really highlights how powerful just moving consistently is.
Really does.
Okay, so once hypertension is diagnosed, the next crucial step is a thorough evaluation. And this isn't just to confirm the numbers again, but really to assess your overall cardiovascular risk and look for any existing target organ damage. Signs that the high blood pressure has already started to affect parts of your body. This could include changes in the eyes. Doctors call it hypertensive retinopathy, basically damage to the tiny blood vessels in the back of your eye, or changes in the heart, like an enlarged heart muscle, which is known as left ventricular hypertrophy.
Right.
So the evaluation involves physical exams, maybe listening for unusual sounds in your blood vessels, those are called Brutes, and essential lab tests like fasting blood glucose, a lipid profile, and an electrocardiogram.
And that EKG, if it's abnormal, might prompt an echocardiogram for a more detailed look at the heart's structure and function.
Got it.
Now, that brings up another critical point. While most hypertension is primary or essential, meaning we can't find a specific identifiable cause, some patients, a smaller group, have secondary hypertension. This does have an underlying cause, and importantly, that cause might actually be treatable, potentially curing the hypertension.
Okay, so not all hypertension is the same then. What are the clues for that secondary type?
Yeah, good question. Clues that might point towards secondary hypertension can include things like a sudden onset of high blood pressure, especially if it's severe, or very erratic, or maybe a diagnosis at a young age, say under 30, particularly if there's no family history of hypertension.
Right. And what's truly fascinating here, I think, is how often clues for this secondary hypertension can come from unexpected places. Like, for example, persistent snoring and excessive daytime sleepiness might suggest obstructive sleep apnea.
A very common one.
Which is a condition where breathing repeatedly stops and starts during sleep. Or unexpected weight gain and, say, persistent constipation could point towards hypothyroidism, an underactive thyroid. Even basic lab tests can offer hints.
Right.
For example, hypokalemia that's low potassium, often accompanied by something called metabolic alkalosis and acid-base imbalance. Well, that could be a sign of primary hyperaldosteronism.
Exactly. And in fact, the 2024 European Society of Cardiology guideline recommends routinely screening for primary hyperaldosteronism in all newly diagnosed hypertensive patients.
All of them.
It reflects a growing understanding that this condition is actually much more prevalent than we previously thought. It really underscores the importance of digging deeper when something doesn't quite fit the typical picture of essential hypertension.
Okay, so let's explore what happens when blood pressure proves to be, well, exceptionally stubborn. We're talking about resistant hypertension.
Resistant hypertension is defined as blood pressure that remains uncontrolled despite being on 3 or more optimal blood pressure medications, and one of those should be a diuretic. Or, alternatively, it's blood pressure that is controlled, but only when you're taking 4 or more different medications.
Okay, that sounds tough.
It can be. But before we label it truly resistant, it's absolutely crucial to go back to basics first. We need to confirm you're consistently taking your medications, as prescribed adherence is key.
We need to ensure we have reliable out-of-office blood pressure readings, like from home monitoring or ABPM. We need to thoroughly readdress those lifestyle factors we talked about: diet, salt, exercise, weight. Plus, we need to check again for any other medications, whether over-the-counter or prescription, that might be unintentionally elevating blood pressure. Things like NSAIDs again, or decongestants.
Got it.
Absolutely.
Now, this is where it gets really interesting, you mentioned. Once those factors are addressed, screening for secondary hypertension becomes even more critical in these resistant cases. It's found in a remarkable 22% of patients with resistant hypertension.
That's right, 22%.
So you can't just rely on the potassium level. No, you can't. It's diagnosed by looking at the ratio of plasma aldosterone to renin activity. An elevated ratio is the key. It just highlights how important it is to keep exploring potential underlying causes when the blood pressure isn't responding as expected.
Okay, so assuming we've ruled out or addressed secondary causes and medication is necessary, how do doctors choose which ones?
Well, the choice is highly individualized, as it should be. It really depends on your specific blood pressure categories, stage 1, stage 2, your overall cardiovascular risk profile, which we calculate, and any other medical conditions you might have. Things like diabetes, kidney disease, heart failure. It's all about building a tailored strategy, definitely not a one-size-fits-all approach.
Right, so for stage 1 hypertension, if you have no established ASCVD, that's atherosclerotic cardiovascular disease, plaque buildup, and your calculated 10-year ASCVD risk is low, under 10%, what then?
Then lifestyle modification is the initial approach. Just focus on diet, exercise, weight, sodium first. We typically reassess after about 3 to 6 months and consider medication then only if your blood pressure is still high.
Okay, but what if you do have established ASCVD or your risk score is higher?
Then the approach is different. You'll likely start with both lifestyle changes and medication right away.
And for stage 2 hypertension?
Generally, treatment starts with 2 medications from different classes right from the beginning, along with lifestyle changes.
2 meds right off the bat?
Yeah, typically. And what's particularly noteworthy here is the nuance in the actual blood pressure targets. While the main ASE-8 guidelines generally aim for a goal of less than 130 80 millimeter Hg for most adults, including those with heart disease, diabetes, or chronic kidney disease, some specialty guidelines, like KDI for chronic kidney disease, actually advocate for even lower targets. They suggest a systolic goal below 120 millimeter Hg.
Wow.
Yes. And for older adults, there was a big study called SPRINT. And the sub-study, SPRINT 75, looked specifically at those over 75. It showed that intensive treatment aiming for a goal of less than 120 millimeter Hg actually resulted in fewer cardiovascular events and deaths compared to the standard goal of less than 140.
Fewer events in the elderly with tighter control.
It was. And surprisingly, it even seemed to reduce symptomatic orthostatic hypotension, that dizzy feeling when you stand up, over time in the intensively treated group.
So what are the main first-line drugs usually?
The main workhorses, the first-line agents, are generally thiazide diuretics, calcium channel blockers, often called CCBs, ACE inhibitors, and ARBs, angiotensin receptor blockers.
Right.
The specific choice among those can be heavily influenced by your other health conditions, like we mentioned. For example, CE inhibitors, or ARBs, are often preferred for patients who have chronic kidney disease, especially if they have proteinuria, which is excess protein in the urine.
Why?
These medications offer an added protective benefit specifically for the kidneys, so it's like a dual advantage.
Yeah. All right, we've taken a really deep dive into hypertension, a critical piece of the cardiovascular puzzle. But as you know, it rarely acts alone. Often, going hand in hand with blood pressure, there's another silent threat to your heart health lurking in your lipid profile. So let's shift our focus now to cholesterol and triglycerides, because tackling both is truly foundational to preventing heart attacks and strokes, which, let's not forget, remain the leading causes of death and disability here in the U.S.
Absolutely. And just as with hypertension, lifestyle modification is paramount here, foundational. Beyond weight management, which is always important for overall health, diet plays a huge role in optimizing your lipid profile. That Mediterranean diet we mentioned earlier, with its emphasis on fruits, vegetables, whole grains, nuts, olive oil, fatty fish, it has been proven time and time again to improve lipid profiles and significantly reduce cardiovascular risk.
Right. And for you, the listener, the immediate implications are pretty clear when you look at the data. Studies show the average American diet is, well, far from ideal. High salt intake, low consumption of nuts and seeds, too many processed meats, not enough omega-3s from fish, not enough vegetables. All these things contribute significantly to ASCVD mortality, to deaths from heart disease. And while, red meat has been controversially discussed sometimes regarding heart health, other research suggests that maybe a high intake of refined carbohydrates, the sugary drinks, highly processed grains, might actually be an even bigger issue driving coronary events.
That's an important point. The focus is shifting. And physical activity, again, is just non-negotiable for lipid health, too. The ACC/AHA recommends at least 150 minutes of moderate intensity aerobic activity per week, or 75 minutes if it's vigorous intensity.
Like jogging.
Exactly. And remember, even short bursts count. The mantra is really, some is better than none. Just get up and move. And resistance training, too, has been shown to effectively lower both LDL cholesterol, the bad kind, and triglycerides.
Okay. And what about aspirin? That used to be recommended much more widely, right?
It did. The thinking has evolved quite a bit based on newer data. Our sources say that for adults age 40 to 59 who have a 10% or greater 10-year cardiovascular disease risk, the decision to use low-dose aspirin for primary prevention, meaning you haven't had an event yet, is really an individual one. You have to weigh the potential benefit, which the evidence suggests is quite small, against the risk of bleeding.
So it's a conversation with your doctor.
But here's a crucial update. For those 60 or older, the U.S. Preventive Services Task Force now actually recommends against routinely initiating aspirin for primary prevention.
Against starting it.
Because the risk of bleeding generally outweighs the potential cardiovascular benefit in that age group for primary prevention.
Okay.
It is.
So if lifestyle changes aren't quite enough to get your lipids where they need to be, what's next?
Then we turn to medications, and statins remain the absolute cornerstone therapy for lipid management. They're incredibly effective at lowering LDL-C, that bad cholesterol. We usually categorize them by their LDL-C lowering intensity. Moderate intensity give you 30–49%, and high-intensity statins lower LDL-C by 50% or more.
Right. Now, a common concern we often hear about is statin intolerance. People worry about muscle aches, the myalgias.
That's definitely a common concern and something we take seriously. But what's truly encouraging, looking at the data and our sources, is that most people who experience these side effects can actually find a way to tolerate statins with some adjustments.
Oh, really?
Well, it might involve trying a lower dose first,
Yeah.
or switching to a different statin because they aren't all exactly the same, or even trying less frequent dosing, like maybe every other day for some specific statins.
So don't give up if you have an issue.
Exactly. It's often worth the effort to work with your doctor to find the right statin and dose combination that works for you, because the benefits are usually substantial.
Okay. But what about for patients who genuinely can't tolerate any statin, despite trying different options? Or maybe they need even more LDL-C lowering on top of their statin?
Great question. For those situations, we do have several powerful non-statin agents now. Ezetimibe is an oral medication. It works differently than statins, blocking cholesterol absorption in the intestine. It can modestly reduce LDL-C on its own, or add about another 15–20% lowering when added to a statin. And importantly, it has been shown to improve cardiovascular outcomes when added to a statin in the improved I2 trial.
Okay, so that's a common add-on. Okay.
Then there are the PCSK9 inhibitors. These are a newer class, given by injection usually every 2 or 4 weeks. They are incredibly powerful LDL-C reducers. They can lower it by another 50–60% on top of a statin. They essentially act like a vacuum cleaner for bad cholesterol, supercharging your body's ability to clear LDL from the bloodstream.
Wow, that's potent.
They are very potent. They're generally reserved for our highest risk patients, like those with familial hypercholesterolemia or those with ASCVD who aren't at goal despite statins and ezetimibe. They are also, as you might guess, quite expensive. Another newer oral option is bempedoic acid. It works upstream from where statins work in the cholesterol synthesis pathway. Its key advantage is that it lowers LDL-C without causing the muscle side effects sometimes associated with statins.
Ah, so good for statin-intolerant folks.
It's a good alternative or add-on therapy for statin-intolerant patients who need more LDL lowering.
Okay. This makes me think about omega-3 fatty acids, fish oil supplements. Many people take those for heart health, right?
Yeah, that's a common question. The general consensus now is that standard omega-3 supplements, the kind most people buy over the counter, generally don't prevent coronary artery disease in most people. However, prescription-strength omega-3s are absolutely crucial for treating very high triglycerides, typically levels over 500 mg/dL. The main reason there is to prevent a serious complication called pancreatitis, inflammation of the pancreas.
So for triglycerides, not generally for LDL or heart attack prevention.
Mostly for triglycerides. But there's one specific prescription omega-3 called icosapent ethyl, or EPA, brand name Vascepa. This one really stands out. A major trial called REDUCE-IT showed that this specific form of EPA can significantly reduce cardiovascular events, heart attacks, strokes in high-risk patients who are already on a statin but still have elevated triglycerides, specifically in the range of 135 to 499 mg/dL.
Okay, so a specific type for a specific group with high triglycerides despite statins.
Precisely. It's a targeted, proven benefit in that population, not a blanket recommendation for everyone.
Got it. So who actually needs treatment for lipids? And what are the goals? You mentioned it's shifted away from just hitting a specific number.
That's right. The whole approach to lipid management has significantly shifted. We've moved away from just chasing specific LDL-C target numbers for everyone. Instead, it's now a much more sophisticated risk-based strategy. Essentially, the higher your baseline ASCVD risk is determined to be, the more intensive the treatment pathway generally becomes.
Okay, so give me an example.
Sure. So, for instance, if you already have established clinical ASCVD, meaning you've had a heart attack, stroke, bypass surgery, stents, or have peripheral artery disease, you're automatically considered high risk. The goal there is typically to start a high-intensity statin immediately, aiming to get your LDL-C below 70 mg/dL.
What if the statin doesn't get you there?
If that goal isn't achieved with the maximally tolerated statin, then ezetimibe is typically added next. And for patients considered very high risk, maybe they've had multiple ASCV events or have ASCVD plus other conditions like diabetes, if they're still not below 70 on a statin plus ezetimibe, then a PCSK9 inhibitor might be considered.
It's a stepwise approach based on risk and response.
Exactly.
Right.
Correct.
Now, what about someone with really, really high cholesterol, but maybe they haven't had an event yet?
Good point. That's another specific category. If your LDL-C is severely elevated, defined as over 190 mg/dL, treatment often starts much earlier, even as early as age 20.
Age 20.
Yes, because that level of LDL is often genetically driven and confers a very high lifetime risk. The goal there is usually a high-intensity statin aiming for a greater than 50% reduction in LDL-C and trying to get the final LDL-C level below 100 mg/dL.
So a proactive approach for those young individuals with extremely high levels makes sense.
Absolutely.
What about the biggest group, probably adults aged 40 to 75, maybe without diabetes, who haven't had an event? How is the decision made there?
Right. That's where it gets more nuanced. For those individuals, we start by calculating their 10-year ASCVD risk score using standard calculators. If the risk score is borderline or intermediate, say between 5% and 20%, the decision to start a statin becomes more of a personalized discussion. And we can refine that risk assessment further by considering what we call risk-enhancing factors.
Risk enhancers, like?
Things like having a strong family history of premature ASCVD, like a parent or sibling having a heart attack young, or having chronic kidney disease, or metabolic syndrome, or even persistently high triglycerides above 175 mg/dL. These factors aren't in the main score, but suggest the calculated risk might actually underestimate the person's true risk.
Okay, so they help paint a clearer picture.
Exactly. They help guide that shared decision-making process between the patient and the doctor about starting a statin.
And here's something I found really interesting in the sources, an aha moment maybe for many listeners. The coronary artery calcium score, or CAS score. How does that fit in?
Ah, yes, the CAC score. It can be an incredibly powerful tiebreaker tool in that intermediate risk group or even in lower risk folks who have risk enhancers. It's a non-invasive CT scan of the heart that actually measures the amount of calcified plaque in your coronary arteries.
So you can actually see the plaque.
You can quantify it, and the results are quite compelling. If your CAC score is 0, meaning no detectable calcified plaque, it signifies a very low short to intermediate term risk, even if your risk score was borderline or intermediate. In that case, it's often reasonable to hold off on starting a statin and reassess things in maybe 5 to 10 years.
That's reassuring for someone with a 0 score.
It can be very reassuring, but if your CAC score is 100 or more, or if it's above the 75th percentile for your age and gender, that indicates a significantly higher risk, even if the calculated score wasn't sky high. In those cases, a statin is definitely indicated and likely to provide substantial benefit.
So it's a really tangible way to personalize the risk assessment and guide treatment decisions.
It moves beyond just statistical risk scores to looking at the actual disease present in the individual.
Wow. We have certainly covered a lot of ground today, from the real nuances of getting an accurate blood pressure measurement and the incredible power of lifestyle changes, all the way through the sophisticated world of medications for both hypertension and lipid management. It's been, a true deep dive into prevention and proactive health.
It really has, and what stands out most to me, I think, is how increasingly individualized these approaches are becoming. We're truly moving away from those older, maybe one-size-fits-all treatments, towards highly tailored plans based on your unique risk factors, your other health conditions, your preferences, even your CAC score, perhaps. It really feels like precision medicine in action for cardiovascular prevention.
Yeah, absolutely. Understanding these insights, we hope, isn't just about absorbing information. It's really about empowering you. Empowering you to have more informed, more proactive conversations with your own healthcare providers. Knowing what influences your risk, knowing how to accurately measure these key indicators like blood pressure, knowing the wide range of options available for prevention and treatment, it really puts you firmly in the driver's seat of your own health journey.
Which makes me think about perhaps a critical next step for you to consider after hearing all this. What new questions will you bring to your next health checkup based on what we've discussed today?